In the interest of time, I'd like to commence. So, ladies and gentlemen, thank you very much for joining today. And I'd like to start by saying interpretation is available for this webinar in English, French, Spanish, and Portuguese. And you can please select the language in which you'd like to listen by pressing the globe icon for interpretation, which is at the bottom of your screen, and it's right next to the reactions button. It's a great pleasure to have you all here with us for this webinar on social participation, inclusion, and community engagement approaches for the health of Indigenous peoples in rural and remote areas. My name is Theodora Swift-Kohler, and I'm Senior Technical Advisor for Health Equity in the Gender Equity and Human Rights team. This webinar is organized as part of a WHO webinar series on tackling rural health inequalities. The series is convened under the umbrella of the World Health Day 2021, which is dedicated to health equity. The series is coordinated with external partners, including WONCA's Working Party on Rural Practice, OECD, and the UN Inequalities Task Team subgroup on rural poverty. The webinar series runs from July to March 2022, and this is the second in the series, the second webinar. Today's event is convened specifically on the occasion of the International Day of the World's Indigenous Peoples, which is focused this year on leaving no one behind, Indigenous peoples, and the call for a new social contract. WHO's 13 General Program of Work commits us to work for populations experiencing situations of vulnerability, including populations who may be experiencing social exclusion and discrimination. WHO is working to address systemic racial and ethnicity-based discrimination in COVID-19 response and recovery plans. For example, by co-leading with UNESCO across UN frontier dialogue process on this topic earlier this year, and by coordinating under the umbrella of the UN Network on Racial Discrimination and the Protection of Minorities, a training for UN country teams on this issue. We are also working to promote primary healthcare strengthening for equitable and resilient recovery. And this includes a focus on promoting the provision of intercultural care and tackling ethnicity-based discrimination to overcome health inequities. Our WHO Regional Office for the Americas has prioritized ethnicity as a cross-cutting theme. This is reflected in its regional policy on ethnicity and health, its strategy, and different initiatives in which the participation and the consultation of Indigenous peoples has been fundamental. It is an honor for us to convene this event on the occasion of the International Day of the World's Indigenous People. Now I would like to pass the floor to my co-chair, Jeffrey Roth, who has been nominated by our colleagues at UNDESA's Indigenous People and Development Branch. Jeffrey himself is an Indigenous person, and he will be the main chair for today's event. Jeffrey Roth is from the Standing Rock Sioux tribe and is vice chair and member of the United Nations Permanent Forum on Indigenous Issues. He has devoted his entire career, spending 20 years, to advocacy for Indigenous persons' rights in diverse sectors, including in health. Jeffrey, it's an honor to have you co-chairing with us today, and over to you, please. Thank you.
Great. Thank you, Theodora. I appreciate it. Ladies and gentlemen, good morning, good afternoon, and good evening. I know some of us, it's a very good morning. I appreciate those of you that are staying up late and getting up very early. It's a great pleasure to co-chair this event on social participation, inclusion, and then community engagement approaches for the health of Indigenous peoples in rural, remote areas. On behalf of myself and the UN Permanent Forum on Indigenous Issues, I want to thank the World Health Organization for planning this session and for inviting me to be here. I want to talk just a little bit more of an introduction of myself. I'm wrapping up my second year at the UN Permanent Forum on Indigenous Issues, and I primarily have been the one that has been working on health issues at the forum. In my capacity in my day job, I am a consultant on American Indian and Alaskan Native health policy here in the United States. And I work specifically with urban Indian health programs, which are NGOs in urban areas that provide health services. I work with tribes, and I work with the government providing advice on health policy. I am the chair of an executive board for the Coquille tribe in Oregon, the state of Oregon, for a wellness facility, a health and wellness facility. I've also co-founded Enaji, which is a health information technology company to exclusively work on electronic health records and telehealth in indigenous communities. I previously worked or was appointed by President Obama to be the senior advisor at the Indian Health Service and served for 7 years in the Obama administration at IHS. And I've also, prior to that, served as the executive director of the National Council of Urban Indian Health. So I've been in the health space for a while, and this, especially during this time of COVID, is an area that's near and dear to my heart. And I appreciate all of you for being here during this difficult time. I truly hope that this is the first of many engagements for me and for the WHO and Indigenous people. As Theodora mentioned, this webinar is taking place on the International Day of World's Indigenous Peoples, this year dedicated to leaving no one behind, Indigenous peoples, and the call for a new social contract. There are over 476 million Indigenous peoples living in 90 countries across the world, accounting for 6.2 million or 6.2% of the global population. Indigenous peoples are the holders of a vast diversity of unique cultures, ancestral knowledge, languages, and knowledge systems. We have a special relationship with our lands and hold our own worldviews and priorities. Indigenous peoples living in rural and remote areas experience limited access to health services. At the same time, where there are health facilities, often staff are not able to communicate in Indigenous languages, or the services aren't culturally appropriate or aren't taken into account in Indigenous people's perspectives or views on the health or well-being. Although numerous Indigenous peoples worldwide have successfully been exercising their autonomy and agency in varying forms, many Indigenous peoples still don't have a voice in decision-making and in the design of health-related interventions, projects, and policies that concern them. To achieve the central transformative process of the 2030 Agenda for leaving no one behind, including Indigenous peoples, and the SDG health-related goals, we must embark on the collective journey to build and redesign a new social contract as an expression of cooperation for social interest, equity, and common good for all. During today's webinar, our distinguished panelists will highlight relevant country experiences fostering social participation, leadership, and inclusion of Indigenous peoples in health-related initiatives and interventions in the context of primary health care in rural and remote areas to ensure a progressive universalism approach. I'd like to introduce our first speaker. Before we start, I'd like to remind our panelists to please keep your interventions within the time allotted so that everyone has a chance to speak. We have eight minutes for our interventions today. So I'll now turn the floor over to our first panelist, Dr. Pavitra Mohan. He is co-founded Basic Healthcare Services, a not-for-profit organization that has the vision of enabling the population in marginalized situations to lead a healthy life with dignity. He will speak about how cohesion and community engagement of rural and tribal populations are constrained by structural factors, social discrimination, and belief systems. He will highlight how building trust, having healthcare providers from within the communities, and responsive services are key to promote Indigenous peoples' participation in their health. Doctor? I think you're muted.
Thanks for this introduction to me and to our work. And I'm really glad to be here, especially when I was invited, I didn't realize that it is the Day of Indigenous People. So I'm really glad that I'm here with others in the panel discussing the health of Indigenous people in India, where a very large proportion of people, especially in several areas, who come from Indigenous communities. I'll just maybe give me a minute. Can you see my screen?
I cannot see it yet.
Okay. Okay. Now?
Yes.
Yeah. Okay. Good morning, good evening to everyone. And what I'll be speaking about are own experiences of working in areas which are predominantly inhabited by Indigenous populations in South Rajasthan, which is a state in the western part of India. As Jeff had introduced, that I work with an organization called Basic Healthcare Services that aims to enable marginalized and vulnerable communities anywhere to lead a healthy life with dignity. And dignity is really an important concept for us. Its mission is to provide high quality and responsive primary healthcare for the last family in the communities that we serve. So even within the communities that we serve, the focus on the last mile and the last family is really there. Just to give you a flavor of the areas that we work in, that there are a very large proportion of tribals in these areas. So almost 70 to 98% population in these different areas that we work in are inhabited by what we call as tribals, or in Hindi, it's actually Adivasi, which is same as indigenous population, people who had been living here forever. The literacy rates are extremely low. Very large number of people in absence of any local livelihood opportunities or farming, which is very rain dependent and erratic. A large number of people migrate out, especially young men, leaving the families behind. And the population density is extremely low, making services and access to services extremely difficult. So the point here is that indigenous is one form of the identity. It's one vulnerability, so to say, but also a strength. But the populations here suffer from multiple vulnerabilities and have multiple identities. They are, of course, indigenous. They are the original inhabitants. But there is also an identity of them being migrants. There is also an identity of a large number of families who are left behind when people migrate, women, children, and elders. There's also an identity and a vulnerability of being remote, of being difficult to access services. They're also, though they are remote, they need not be underserved, but being underserved by public systems, by societies, another identity that they carry and another vulnerability that ensues. There are also food scarce communities because, as I said, that the land sizes are small and the agriculture is rain dependent. Therefore, food is really scarce. Within the society, they are also marginalized because of their place in the hierarchy of the society, and therefore it is no wonder that they are impoverished, and there is a lot of gender discrimination within those societies. So for a woman, there would be an additional vulnerability of being further marginalized within this kind of frame of vulnerabilities. So when we talk of health of indigenous populations, we believe that we have to understand that they have multiple identities, and being indigenous is one of them, which many a times is there are other vulnerabilities that kind of add onto that existing identity. So how does one really work and engage with the communities in promoting their own health? I think one of the important principles that we try to follow is to not look at indigenous populations as victims, but as agents of change, and therefore inclusion and participation in every aspect of healthcare is critical. And one of the approach is to provide a responsive and trustworthy service, which is really designed to respond. I think the design is really important. If it is really closer to where people live, it is based in the communities. The clinic that you see here is leased out by the community, and it's kind of their building that is in which the clinics run. Respond to their felt needs, the illnesses or the conditions that they feel are critical for them, and responding to their needs rather than a top-down structure of what is really required in these populations based on an epidemiology or a top-down understanding of what people need. And really critical is having providers who themselves are tribal, especially women providers, because for women, as I said, suffer from additional marginalization, and having women providers and people from the same community is really, really critical to ensure participation of the communities and their inclusion. You see here a young nurse from a tribal community with another person who suffered from COVID and was managed in a remote community clinic and standing there. I think what we also need to understand is that there is change, that there is some echoing in my computer. Okay, so that the communities are changing. So while, typically one would think of indigenous as a static community with a certain belief systems and lack of education, of modern education, etc. But increasingly, there are a large number of young girls, for example, who are turning out to be nurses, and some of them going on to become doctors, etc. And so having these providers working in such communities is extremely critical to include women, to build the trust that is so critical for the families in the communities to seek care and to participate in healthcare. Of course, and by doing so, and by designing such services, you can communicate in the similar language, understand the context, and understand the problems and the pains and successes of these populations. For a design of such a service, we believe that task sharing, task shifting is really important. You have to devolve what a specialized hospital can do to a primary care clinic, what a primary care clinic can do to a community health worker, etc., because that expands the span of community participation. Highly specialized services tend to be elitist and away from people, both physically and there's a social distance as well. And such a service would, of course, engage community volunteers, of which I'll talk more later. The second approach that I'll be talking of is of community oversight of healthcare. How do you participate in management of healthcare services, and not only as a mere beneficiary, but as a group that oversees and advises and supports and enforces accountability on healthcare services. For example, in the clinics that we run, there is a community advisory group which consists of members of the community, men and women, that provides feedback and advice on what we should do. They ask for accountability, but also assumes responsibility for community action. For example, in several cases where there have been outbreaks of malaria or viral diseases, the group has taken on responsibility for promoting community action to address these issues. They also enforces accountability on the services by asking us difficult questions on how the services should be run, how the access to service should further improve, or the quality needs to be further enhanced, etc. The third, which is really critical, and it relates to the first point that I made about the multiple identities and multiple vulnerabilities. And because there are multiple vulnerabilities, addressing only healthcare will be insufficient to empower and engage and promote, inclusion in such areas where, for example, the livelihoods are a real problem, and therefore converging with the other services which improve skills and livelihoods, which organize and ensure linkage to entitlements of the left behind families, which provide childcare opportunities and childcare services. So converging with other sets of services in such populations is both empowering and also expands the scope of participation. Health education, of course, is a simple kind of a concept, and extremely important when working with remote communities with traditional belief systems and context, and therefore engaging volunteers who are from the same community, who understand the context, and also for the rest of the group to understand the context and beliefs and address them on while kind of imparting health education or information or skills on healthcare to the communities. It has to be built on a culture of empathy, mutuality, and support, which is a kind of a work culture issue. And I think any service or any healthcare initiative that needs to work in such areas, an inordinate effort has to be made on building such a culture. In probably in any communities, but especially in communities which has their own kind of hierarchies and leaderships, and based on the tribe or on the religion, etc. It is important to work with a wide range of stakeholders and understand that hierarchy. For example, in our case, while working during the COVID pandemic, there was a lot of resistance initially to seek treatment and to get immunized among some of the populations that we work with. Working with the leaders, completely transformed the scenario where from being extremely hesitant to openly embracing treatment and vaccination. And the involvement with such, of course, needs to be built on trust. Another, I think, cross-cutting learning and a principle that we felt is that there have been historical inequities and exclusion for hundreds of years. And patience is really important for promoting inclusion, for promoting access to care, and for promoting healthier behaviors. And that many times the initiatives tend to be impatient, and that leads to a very top-down kind of approaches, which further excludes populations rather than including them. Finally, what really many of our volunteers and community members, when you go out and talk to them, they say it's ultimately a matter of trust, right? I mean, building relationships, building trust, which leads to inclusion, which leads to participation. In this, I would probably never forget this picture, because this was in the middle of a bad pandemic of COVID in some of these populations, where we met this woman who herself was infected. But on seeing us, there was a trust. She said that, yeah, I really need treatment. And then she brought another women from her communities to come and say that, she's also unwell and she needs treatment. So in the end, a lot of it is about building trustworthy relationships and trustworthy services and initiatives. Thank you very much. And we'll be very happy to kind of discuss this further with anyone who's interested. Thanks so much.
Thank you very much, Doctor. Really appreciate it. I have the pleasure now to introduce our next speaker, Fernando Jose de Mora Nito. He is indigenous of the Pitawari ethnic group, also called Patewara. The Pitawari are indigenous group that inhabit the Pitawari indigenous land in the state of Ceará, Brazil. Mr. Mora Nito is president of the District Council of Indigenous Health of the state of Ceará and vice coordinator of the Condesi President's Forum. Mr. Mora Nito will speak about the model of social participation for indigenous health in Brazil, the creation of forums and collegiate bodies that work for the health of indigenous people. The theme of his presentation is Indigenous Healthcare Subsystems. Mr. Nito? I think you're muted still.
Muito bom dia, muito boa tarde.
Good morning, good afternoon, good evening. First of all, I would like to thank you for the opportunity to celebrate the International Day of Indigenous Peoples. I would like to thank you for your trust and for the invitation to be here, and also for the trust of my co-colleagues. Today in Brazil, we are more than 5,000 counselors that are distributed throughout the country. We are more than 374 local health councils for indigenous population. The model of indigenous people's health in Brazil was created according to the law 842 and guarantees the participation of indigenous people in the universal health system. We have participation as indigenous people, and as my previous colleague mentioned, I would also like to highlight the importance that we had during the COVID-19 pandemic, from the elaboration of plans and facing COVID and the creation of sanitary barriers inside our communities and the effective participation in politics. We understand that this subsystem is created for the Indians, not only in the law, because it is also made by Indians for Indians. And I'm honored to be part of this system. It was also created according to a law in 2002, and this is a reason for satisfaction. This subsystem works, it is effective, and we can take life to our communities. We have this differentiated model that covers all different legislations, but we also respect it. This is why our system is different. We respect the cultural and the geographical differences of each culture. We also respect the indigenous people medicine and the spiritual aspect of the spiritual medicine in the indigenous tribes. The people who work in this subsystem must be aware of all of these differences. Our professionals, those who want to work in our communities, need to understand the spiritual aspect of health. During the pandemic, we were faced with surprises, especially because of all the losses we had. Today, I want to honor and remember all these people, while we celebrate the International Day of Indigenous Peoples. And we would like to highlight the role of the counselor, and this model is new in Brazil, but it can also be replicated elsewhere. We want WHO to help us to expand this model. This model is a social model. It is not only based on rules and regulations. We also have practical experience. We know it works. And we always develop things in each community. This is the most important. And this has been proven in this pandemic, even in those communities that were difficult to reach, where we could not take vaccines, where we had barriers, religious barriers, we worked with our counselors and sensitized the communities and the leaders to the importance of vaccine. The COVID-19 pandemic affected the entire health system in the entire world. And our counselors here, they really had to work hard during this pandemic. Today, we celebrate the presence of indigenous people at the UN. It is a great satisfaction to be here talking to the world, talking about the importance of indigenous peoples. It's also important that we are articulated. I don't like to consider indigenous people marginalized. I believe that indigenous people must be actors of their future. I am part of it. I am 27 years old. I live within an indigenous reserve that has been already marked. And I have shown that one of the policies for indigenous health works. Not only do we have access to health in our community, we have an entire spectrum of health services from birth to death, and all of this in the community. All of this has to be very clear. We need to respect our practices, our rituals. We had to talk to our leaders and explain to them that currently under the pandemic situation, we could not carry out all the rituals as we used to, but that these rituals could be adapted to a smaller environment. We are still working with the pandemic, and we always reinforce with the leaders the importance of the WHO measures. We always tell our leaders they have to follow the health measures of WHO and of the Ministry of Health. We tell them that right now they cannot perform certain rituals, but this is because we want to preserve the health. We want to highlight the partnership with WHO, but also the partnership with our indigenous workers. We have over 700,000 health workers who are from indigenous from indigenous tribes. He corrects himself. We're 14,000 health workers who come from indigenous tribes. These are health counselors who live within the community, and this is very important for us. Our healthcare professionals, they are very important, and I would like to highlight their importance. We need to understand and improve health systems, not only in indigenous communities, but also everywhere in the world. We need to improve health systems. Again, I would like to thank you for your invitation. My time is up, but I am available for questions or for more information about our system. And I would like to wish you a happy.
Thank you, sir. I really appreciate hearing what you have to say. I really, I want to point out, what you talk about, ensuring that our indigenous interventions are led by indigenous people. And I also want to, also point out the need to have our indigenous people caring for our indigenous people, our counselors being indigenous people. I'm glad to hear about that. And the other thing that we all need to remember is that, this all takes financing and partnerships for financing. And so that we need to remember that we need to find ways to finance globally this. It's not that we want to be insular in our communities and we don't need financing. We do need financing. We do want to stay insular and we want to stay by ourselves, but we do need financing in order to pull these things off. I appreciate it. Our next speaker, our next speakers are Novaleen Alsen-Goklish and Francine Larzeller, who jointly will speak on the experience of the White Mountain Apache Tribe, community engagement, and social participation in responding to COVID-19. Ms. Goklish is a member of the White Mountain Apache Tribe and is currently a research associate at Johns Hopkins Center for American Indian Health. She's worked as a behavioral interventionist for the Apache tribe for over 20 years, including teaching parenting to young Apache women who are pregnant, as well as coping skills for Apache youth who have made recent suicide attempts. Ms. Francine Larzeller is also a member of the White Mountain Apache tribe and currently serves as a research associate at Johns Hopkins Center for American Indian Health. She's involved in behavioral health, infectious disease, and training projects, providing support in many aspects of the research process. Please. Thank you.
Good morning. This is Novaline Goklish. Can you hear me?
Yes.
Okay, thank you. So thank you for the introduction, Joffrey. We appreciate that. Good morning to everybody. Good afternoon and good evening for those of you who are getting ready for bed in a bit. Thank you so much for inviting us to participate in this presentation. Like Joffrey stated, myself and Francine are members of the White Mountain Apache tribe, and we worked extensively with our tribe and our local Indian Health Service hospital on the response to COVID-19. If you could please go to the next slide. We are located in eastern Arizona on a reservation. It's a rural area. It takes us about 3 to 4 hours to get to Phoenix and Tucson. Those are the urban cities in Arizona. And our first positive case happened on April 1st. Of all dates for it to happen, people were like, are you sure it's April Fool's? But yes, that's correct. It was April 1st of 2020 when we had our first positive case, and our tribe responded in a very responsive manner and started mitigating a lot of safety measures. Next slide, please. As you can see, we responded by supporting the community. We started delivering non-stop food and mask delivery, so non-perishable items to our tribal members who were placed on quarantine, and tribal members that needed food because they don't have transportation, as transportation is a barrier in our community since we're so rural and spread out a little bit. We also prioritized our elders, making sure that our elders received food throughout the pandemic so that they would minimize having to go to the grocery store. We also provided baby supplies for small children throughout the community as well, those that were in need, because it was really difficult for them to go to the stores because of what was happening throughout the world. Next slide, please. White Mountain Apache Tribe Specific Health Communications. This is a document that was developed in collaboration with our tribe, the Indian Health Service, and CDC, along with Johns Hopkins University, on what needed to happen and what our tribal members needed to understand, what was taking place within the community, and what they needed to know about COVID-19, what the coronavirus disease was doing and how it was affecting our community members, what were the symptoms, what the community members needed to do to keep themselves safe. And a lot of this was translated into our Apache language. We had PSAs that were created on our local radio station, and we also delivered flyers door to door with the food boxes so community members understood what was going on and what they needed to do to keep themselves safe. Next slide, please. Enacting tribal policies throughout pandemic based on evidence-based and CDC guidelines. So our reservation, our tribal leaders initiated lockdown and curfews, mask mandate, decisions for reopening based on real-time data analyzed by the Indian Health Service and Johns Hopkins. This was really important for us to do because it helped us to mitigate the spread of COVID-19 and also to make sure that our tribal members were going to remain safe. Next slide, please. There was an article that was published in the New York Times identifying that, we had the highest rates. It was 10 times the rate of people in the United States or in the world, and that the spread was really significant, but the death rate was really low because of the safety mitigations that were put in place, and you'll see that on the next slide. And I'll hand the presentation over to my colleague, Francine Larzalier. Thank you.
Good morning, and thank you for allowing us to present. I'm going to use Novaline's speaker. We're in the same room. So as you can see, there was a lot of collaborative efforts between Johns Hopkins, the White Mountain Apache Tribe, and the Indian Health Service to really focus on, supporting individuals who are in isolation and on quarantine. We had a lot of testing that took place throughout the community and vaccine implementation once the Pfizer vaccine became available, and contact tracing. And contact tracing really was at the forefront of why the numbers of deaths in our community was not more significant. The Indian Health Service, some of our Johns Hopkins staff, and some of the tribal staff members were able to go out into the community and make contact with people, households who were on quarantine, and test other people within the homes to make sure that everybody was, safe, primarily the elders, checking on them, making sure that they were doing okay. If their symptoms got severe, they were able to then transport to the hospital if necessary. Next slide, please. So we were able to put together weekly data reports for the tribe. The Indian Health Service would send us some data numbers for the given week, and we were able to do a data analysis. And so as you can see, the first graph starting from April 1st, and we peaked like in June, mid-June, we started to see a decline up until around October, and then we started to see another increase. And as we continued through the pandemic, things have calmed down a little bit. We're seeing another small spike right now, but for the most part, we've been able to keep that curve down. And then on the second graph, you can see starting April 1st, how that declined over time. So our weekly data summaries provided to our local tribal council. It's broken down by age, total number overall, males and females. And you can see that the number of cases is really high between the ages of 25 and 54. Our elders were our priority, and so making sure that they were safe was important. And then you can see in the bottom graph as well that 53% of females had tested positive for COVID and 47 males. And then just a hospitalization rate based on age. Next slide, please. Although we've had high rates of COVID within the community, our vaccination rates have also been very high. And you can see that our older population, our elders, are at 67% of being fully vaccinated for our community. And it goes down, as you can see, based on age. However, we are doing really well overall. Next slide, please. We also know that, people's mental health has really become a priority. We know that being on quarantine and isolated and not being able to participate in the traditional ceremonies has really affected people, and also individuals who participate in, going to church and other activities. And so we really wanted to focus on some health promotion. And so that's currently one of our focuses at this time. Next slide, please. And so some of our ongoing projects in collaboration with our tribe and the Indian Health Services, we are still doing the Pfizer vaccine trial. We're now transitioned into the booster phase of that trial. We continue to do antibody testing. We're still continuing to do surveillance and long-term follow-up for people who have either tested positive for COVID and have received the vaccine. We've had interventions for the rapid testing. We also have a Safe Schools project. And so our staff are currently helping the schools to reopen in a safe manner, continue testing. We've also just received funding to do some mental health interventions, and we continue to provide media and campaign communications about the vaccine and all the other programs that are currently happening within our community. And I believe that was the last slide. Thank you.
Thank you very much. Is that it? Novaline?
Yes, that's it. Thank you.
Thank you very much. I just wanted to note that you all are doing the Pfizer trial, And, I know it's hard for our communities to get involved, especially with medical research. And, in a sense, you're doing work for all of us, for all of our Indigenous communities. And so I just want to say thank you for that, and thank you for continuing to do that work. It's appreciated globally for Indigenous communities. So thank you.
Thank you.
Our next speaker is Joseph LeBlanc. He's a lifelong Northern Ontarian and member of the Wewemkong Unceded Territory. He has worked for a diverse range of organizations, including academic institutions, Indigenous organizations, and nonprofits. Currently, he serves as the Associate Dean, Equity and Inclusion of the Northern Ontario School of Medicine in Canada. Mr. LeBlanc will present an experience on social accountability with Indigenous communities for the training of health professionals in Ontario, Canada. Mr. LeBlanc?
Hi, everyone. Thank you for having me. I appreciate the opportunity to share and appreciate what's been shared already by my co-presenters. So I'll just share my screen. Okay, can you see that?
Yep.
Perfect, thank you. All right, so I'm going to talk a little bit about setting the context, talk a little bit about our school and what social accountability means there, and then specifically what we're doing in the area of decolonizing medical education. So as was said, I'm positioned here in Northern Ontario. Our campus and region spans about 800,000 square kilometers throughout the north of Ontario in Canada. And our areas of focus are to address the social and health inequities in Francophone and Indigenous populations. Canada is continuing to reckon with its colonial and genocidal history, and wanted to pay tribute to Joyce Echaquan, who live streamed her death in a Quebec emergency room last year, including taunts and other ill treatment from health professionals, and this has spurred on focus. And so we want to thank her for her wisdom in those final moments to share her experience. More and more across the country, the identification of systemic and interpersonal racism, as well as actions to address. And so this is a quote from leadership within our territory, whose spouse passed without proper oxygen at the health center, and so he walked 400 kilometers on a nice road to drag an oxygen tank to prove where there's a will, there's a way. But the quote really does resonate. And so as a school here, founded in 2005 with the concept of social accountability, some of you may be familiar with this model for social accountability in health education, and really problematic in its design in that it marginalizes community further and further entrenches health professionals as authority. And so we tend to lean a little bit broader to what is defined as community and engage as community members as opposed to something separate. So, what does it mean to decolonize medical education here at NOSM? Focusing on recruitment and retention of priority populations, including and centering diverse knowledges and ways of being and ways of thinking, rethinking our partnerships and the relationships we have, looking at contextual fluidity, the diversity of our region spanning, like I said, 800,000 square kilometers, including 30 or so remote communities, fly-in communities, and many rural communities means that we have to be fluid to the particular context and recognize our positionality within this complex systems. So working to address racism, institutional, as well as the perpetuation of imbalances. So, specifically, I'll talk about each of these in greater detail, but, wanted to focus today's presentation on these interventions and what it is that we're doing specifically to, work with and for Indigenous populations. Within the admissions area, right, it starts right in childhood, focusing on pathway programs, working with local science educators to develop an interest in health careers as a pathway, as well as building strong connections back with alumni and creating opportunities to see role models. We have an admissions stream in which an Indigenous admissions committee, which is chaired by an Indigenous physician, as well as participated on by leadership and education leadership, selects our applicants, and we do have a focus on ensuring there's a particular population represented within our student body, which is about a 20% target. So we're a small school. We have a 64 seats, and we're targeting about 20% of those to be for Indigenous trainees. We do provide some training for multiple mini interviews for Indigenous applicants, in which we have physicians, Indigenous physicians, and medical students lead that and support their preparation for those interviews. Focusing on orientation, where we bring traditional medicine practitioners for the entire class to meet and work with. And then we do have a remote residency stream in which we have residents training in Yebmatung First Nation, a remote community here in the north. As far as the curriculum goes, we have what we call CBM 106, our community-based module. All of the medical students spend 1 month immersed living in an Indigenous community. We partner with 46 local communities to provide this opportunity, and the community members create and lead the delivery of the content and curriculum during those experiences. We have a theme 1 focus, so we have, like I said, addressed some of the structural elements by creating these focal points and inviting leadership to there. I'm having some echoing in my thing, so apologize. So, with the new now introduction this year will be the first year for the curricular specialization. So it's called the Indigenous Peoples Health and Wellness stream, in which learners will still meet all of the competencies for medical education, but will participate in learning in Indigenous context. So we're really hopeful for that, and like I said, this will be the first year coming in. Also, the creation of cultural faculty positions is in the works, which will acknowledge, Indigenous medical healers and practitioners as faculty. So, integration of people in leadership. We have a number of structures which this occurs, and they all have a particular focus. So I mentioned the admissions committee already. We employ local community coordinators in the communities in which 106 occurs. So they're primary liaison there. We have an Indigenous Affairs unit, which supports the cultural and community connections for faculty, learners, and staff, as well as a reference group made up of community members and leaders, and a newly created Indigenous Health Education Committee, which is actually part of our highest academic structure and is responsible for the oversight of curriculum development and renewal, as well as the participation of an Indigenous clinician circle. Focusing on really zeroing in on staying in our lane, and where we have an opportunity to influence change. Our focus is, yes, on curriculum as well as on recruitment, but also on advocacy and public education. Some of this took, more of a forefront during the pandemic, but generally, we would hold knowledge sharing circles, about 20 of them a year, in which knowledge keepers would come to campus and share and reflect, what's happening in the world. We have a Center for Social Accountability, which works to liaise with communities to develop research and other opportunities around public education, celebrating and sharing Orange Shirt Day, which is a commemoration here on September 30th of the residential schools, and this date coincides with the date in which students needed to report to the school. So we typically will have survivors and other people speak about that day, and have a Dean's Lecture Series as well that's focused this past year on racism. And then, like I said, addressing structural and interpersonal issues. We fund cultural interest groups, which the students, Indigenous students lead, and they participate in, crafts or feasting or other things. We support networking and mentorship, so we'll support membership fees in groups like the Indigenous Physicians Association of Canada, provide travel support, host feasts for our learners to connect with each other. We've created opportunities for cultural and community connections as professional development. So this is, the ability to go to a medicine camp or something along those lines, provide academic supports, and really, work to follow the guidance from Indigenous people. So health transformation that's being undertaken in our region, truth and reconciliation, missing murdered Indigenous women and girls, UNDRIP, and these are all examples of things that we integrate. So, I want to leave you with this idea that, often when we look at these systems of care and systems of education, they seem like these, powerful sort of immovable forces, like these raging rivers. But, we focus on how ultimately you can change that trajectory by the land and shaping that. And so, a lot of these are small stones being thrown into a raging river. We work to collaborate with others to find, bigger and bigger rocks to throw and eventually change that. And so, as we move forward, some of these key concepts are things we can do alone, and others we need collaboration. And so we work very closely with communities and leadership, within our area. And I want to thank you for your time. Hopefully I haven't gone over too much, and open to any continued conversation and questions or follow-up afterwards. So thank you, Chimigwech.
Thank you very much. I think that we have so much work to do in, the professional development area, and especially with our people, and the need is so great in our communities, and not just our communities, everywhere. Everywhere we turn, we have such needs for providers, and I think, unfortunately, we don't always get the best providers in our communities sometimes. And I think that it's best to have our people providing services to our people. So I really appreciate your efforts. So. Our next distinguished speaker is Dr. Miriam Wallet Aboubakry. She's a Tuareg woman from Timbuktu, Mali. She has a multidisciplinary background in medical sciences and humanitarian studies, and is the former chair, 2016 to 2018, of the UN Permanent Forum on Indigenous Issues. She's a board member and leader of several Indigenous-led organizations, and co-principal investigator of the Aramat Network, of which I and other people on here are members, and she's also one of my mentees. I'm also a mentee of her, excuse me. Look up to her. She'll speak on the leadership of Indigenous women as the first responders to questions that affect them and their communities, drawing on the example of an awareness campaign against COVID-19 in 2020 in Timbuktu. She will also talk about opportunities for collaboration with multiple stakeholders so that Indigenous women can contribute to their full potential and well-being and for the benefit of their communities. Miriam?
Merci, Geoffrey.
Thank you very much, Geoffrey. Good morning. To start, I would like to start with a prayer in my language to recognize the land. So I'm going to read the prayer in my language.
نموياك أواصل نجشد منك الداشي داخل عن مجراوف الساحة لنا نموياك تيساق تانجيرينا إن ساندرا ديل بينو دكتور إيجيمك سوزانا هكد الدينة ويدارة مشغل ندفو تمايتي أرامة التين هنان في العواس نموس السباب جيت موقع استعرق donc la prière est finie.
The prayer has ended to pray for the land. I'm very pleased to be part of this initiative to celebrate the progress made in our cooperation with the WHO. I can say today that it is an honor for me to participate in this conversation, given that we are in the WHO with such a broad representation socio-culturally of Indigenous peoples. Before I delve into the initiative that I had planned to speak to you about, I would like to introduce you to Indigenous peoples in Africa. Now, Indigenous peoples in Africa include 77.9 million people, approximately, of which 38.7 million approximately are women. Even though they are often associated with rural areas, we are realizing that there is a growing indigenous population in urban areas, even in Africa. Furthermore, Indigenous peoples face a number of challenges, and they are multifold, such as, for example, education. There are also threats to their way of life and even their survival, because those two are intimately linked. There are threats to biodiversity, which is a growing challenge. What is happening to nature has a direct impact on their spirituality. I'm sorry, I'm hearing my own voice. Is that normal? There's an echo. Well, as I was saying, there is a growing loss of biodiversity which is weighing on these populations, and this directly impacts their spirituality, as well as another dimension, the species that those peoples and communities depend on to eat, for example. There are also challenges accessing basic services. I'm thinking of education, healthcare, and other infrastructures which are absolutely decisive when it comes to health. When there are services, they do not often take due account of the cultural specificities of these peoples, and also there is a growing lack of safety throughout many places, including indigenous territories, and this was aggravated by the pandemic. Now, when it comes to the contributions of indigenous peoples, we have to realize that they safeguard the territory, they safeguard the land, And this is something that we must bear in mind, because when we look at reaching targets for development, be it to fight poverty or meeting SDG 3, as Diouf Ferot, our co-moderator, says, we have to focus on those 77.9 million people. If we ignore them, we will not be able to meet the SDGs. Now, let me show you the initiative itself, the awareness-raising campaign run by one of the organizations that I am part of, which is an Indigenous Women's Association. Hand in hand with women and indigenous peoples around the world, we, native people from Timbuktu, decided to take note of the alarming situation given the health situation, and we decided to approach OCHA. And in 2021, our region had the highest number of confirmed COVID-19 cases. And this is certainly an underestimate, given the difficulties accessing diagnostic tools, because during the pandemic, to confirm cases, samples had to be sent to Bamako because there was no way to carry out PCR tests on the ground. So this is the backdrop against which us as Indigenous women decided not to simply rest on our laurels. We decided to deal with the issues that are facing our community to the extent of our capacity. I myself recorded a number of videos which confirmed to the population that the COVID pandemic existed, because, as other presenters said, there was a lot of doubt about the existence of the pandemic itself. And as a well-known person in the region, I confirmed the existence of the pandemic, and then I shared culturally tailored information to help people protect themselves from the pandemic, because it would make no sense to ask people for hydroalcoholic gel if that was not there, or whereas we have resources in our community which might be better to promote. And we talked with people. So that's exactly what our organization did. When we started the initiative, we were not alone. There were other Indigenous peoples, women who helped us, such as, for example, the Indigenous Women's Association in Paris, in Africa rather, who are based in Nairobi, and they support Indigenous African women throughout the continent, and they supported us, but also local authorities and multiple humanitarian partners at least opened the door and welcomed us and helped our initiative gain notoriety. Now, let us speak about the goals that were part of this campaign. We were trying to contribute to protecting Timbuktu populations against COVID-19. And when I refer to Timbuktu, I'm not just talking about the city, but rather the surrounding area. We also wanted to demonstrate as part of this initiative that with not that much materially but lots of determination and women's leadership, it was possible to make changes, to make a difference, to act without having to just wait. We were also able to confirm that the populations can help themselves, and so we need to empower those populations themselves. And so what measures did we use? Well, I disseminated my personal message that I referred to before, but with other members of our association, we developed other messages which were more in-depth and in tandem with the community, not just my community. There are other communities present, so we created specific messages, oral messages, because a lot of people in those communities are illiterate, so we sent messages as well through WhatsApp, which is very used in that region, and we created core messages to raise awareness about the symptoms, the means of transmission, means for prevention, and where to go if there's a possibility of there being a case. As I said, we were the resource people in the community, so we know exactly who are the people who can't come.
Aide humanitaire. Du fait de la limite du temps, je vais juste vous passer un petit...
Humanitarian care. One of the messages that we produced in one of the languages
Donc, j'ai fait un...
So I made a short message. I know that you cannot hear any translation into French or any of the other languages, but the gist of this little part that I included is exactly what is relevant and what is culturally appropriate. It also bears in mind the knowledge base of the population vis-a-vis the illness. So it is not simply translating it to the language in question. All of these messages must be culturally tailored to the population so that they can take it on board. Now, what lessons can we take away from this experience? And on this photo, you see the governor of the Timbuktu region, who symbolically gave the protection kit with local soap and hydroalcoholic solution. This was symbolic because we did not want to work in silos. Joseph Leblanc was very clear, and other speakers were very clear, and we agree with them that we wanted to change the way of thinking so that indigenous communities could respond to their own health issues, but we all have to work together so that our actions can be complementary and can be broader and more sustainable. Now, the lesson to take away from this is that as indigenous peoples, we are key stakeholders in our own health. We have seen that women already take care of their own family. They are the best responders. They know better than anyone how to respond and where to find ill people, those who need support within their own community. They are also experts when it comes to intra-community relationships. Who are the different players on the ground? Because that's something that is a resource. I think that I might actually go over time because I'm very passionate. The next steps: coordination and cooperation with indigenous leaders and making them visible. And by way of conclusion, I will say that what is on the screen, which says that women are the pillars of the community. So we have to focus on women. And whether indigenous people are in the forest, the mountain, or elsewhere, they eat and live in that place, and we have to cooperate with indigenous peoples with appropriate care, culturally tailored care, and also appropriate funding. Let us make them visible, let their contributions be visible, and let us favor their own health by helping them, by carrying out research in tandem with them. Thank you very much, and I'm sorry for going over time.
Thank you, Miriam. I appreciate it. I appreciate highlighting the central role and leadership role that women play in all of our communities, the need for us to ensure that we entrust our health and leadership in women. I think we need to. I think that's the key to many of our problems and solutions. So thank you. For our next intervention for this event, we count on the participation of Ariana Valenzuela Pajang. She is a Mapuche, born in the 9th region, currently living in Cochrane-Aishan region. She is an indigenous leader and president of the Liafu Ni Pup Nin Baker Indigenous Association. She will be speaking about equity in rural health of indigenous peoples in Chile and the actions and or programs implemented by the government to ensure equitable access and culturally appropriate health services for indigenous peoples, including traditional knowledge models. We are running a little bit behind, so I'm just hoping that we can kind of maybe go a little bit faster, but I think I do want to make sure that we are able to have Ariane and then our next speaker speak as well. So thank you.
Buenos días.
Good day.
Bueno, a mí me toca hablar.
So, I want to talk about community commitment for the health of indigenous populations in rural and remote areas in my country. In Chile, 12.8% of the total population belongs to native populations, which represents 2.185 million persons. Of these, 80% self-identify as Mapuche, which is about 1.745 million people. 25% of these are located in rural areas. The regions that have the highest percentage of Mapuche are Metropolitana, Araucanía, Los Lagos, Bilbao, and Los Rios. This is according to the census carried out in 2017 by our National Institute. For indigenous peoples, health is a holistic thing that comprises a broad understanding. Thus it is that their cosmovision is a cross-cutting one that connects physical well-being with spiritual well-being. Values include respect for nature, traditions of the past, and this relates also to protecting our identity and our culture as a people and as a country. Health has had to face an important challenge, mainly due to the extreme geographic situation in which Chile finds itself. Thus it was that in 1996 the Special Program for Indigenous Population Health came about. This took place within the broad primary health unit of the Ministry of Health. Thus it is that it addressed the health of indigenous populations, trying to provide medical assistance with an intercultural approach, looking at the systems and medical practices of indigenous peoples. This effort was strengthened with the program called Origins in 2000. It wanted to develop intercultural models to provide healthcare as well as health management to improve the quality, awareness, and cultural appropriateness of healthcare services in indigenous territories. Also to strengthen indigenous medicinal practices and the problem-solving capacities of these intercultural networks and services. We wanted to continue to make progress in intercultural public policies, and thus it was that in 2017, the General Technical Standard 189 was adopted, which enshrined the handover of the placenta in a broader instrument, Decree number 43/2016, which states that the placenta shall be handed over to the woman when required for their medicine and for carrying out cultural practices that the woman deems relevant. Article 6 bis. The General Technical Standard aims to guarantee the right of women to have access to the placenta, respecting their cultural practices from a perspective of the indigenous cosmovision. The placenta is a symbol of life. It represents the relationship between the mother and child. Its use in ceremonies is reserved for an intimate setting, which will allow the family and their closest relations to reaffirm the bonds that connect them and that will provide for care of the person. In the past, in Mapuche culture, we saw that when a woman gave birth, the placenta was planted in the earth, Mother Earth, and it was considered a seed that would also be planted with a tree seed, and all this would germinate together, and this would represent the new life that this newborn would have, which is why this is so important for us.
Perdón, acá en nuestra región yo vivo en...
Please forgive me. I live in a remote part of Chile, and that's why my internet connection isn't the best. Please forgive me. Let me continue. The dominance of Western medicine means that we forgot how in the past humans have tried to cure their ills with natural components that were available in their environment. Thus it is that medicinal plants were essential in the medicine of the past. That is how our ancestors built their knowledge, and this combined with the knowledge of the Spaniards that came with their own European medicinal plants. Ñuquemapu, Mother Earth, has given us what is necessary to cure diseases and the afflictions of her children. This is where our healers come in. We call them machi in our culture, mine particularly. Our government continues and will continue to provide for the health requirements of indigenous populations, supporting ancestral medicinal practices with different measures. CONADI, the National Corporation for Indigenous Development, and the Service Center Magallanes published a book on ancestral medicine that covered the indigenous populations of Mapuche, Kawesa, and Yagan. This book compiles research made by historians, priests, and the current cultural facilitators, which are part of the health network, and that tries to respond to the specificities of indigenous populations. This book looks at background regarding the notions of disease and healing in accordance with the cosmovision, the worldview of these indigenous populations in the south of the country that live between, including the big island of Chiloé and the Cape Horn archipelago. It includes further research and testimony from cultural facilitators that pay heed to the effectiveness of these indigenous practices. The photos you see on screen now relate to a project that started last year and screening for breast cancer. As I said earlier, we're populations that are very remotely located, far from major population hubs. However, these communities are also far away from the regional capital, so they're extremely remote. To be able to carry out breast scans is absolutely essential because of the high rate of breast cancer. And that's why our government has made a special effort to carry out preventive early testing to identify its emergence. That way we can avoid deaths, and so that the treatments are successful. Thanks to our Minister for Social and Family Development, Ms. Carla Rubiar, and the Special Advisor for Indigenous Affairs, Ms. Ana Bayano. They welcomed my demand to create a team that would address these needs of the women of the area of Cochrane, Tortel, and Villa O'Higgins. That way they can carry out this sort of test. Otherwise, there would be no way for us to access these tests or to go to places where they could be carried out because, once again, we are in such remote areas. Over May of this year, we had the first rollout of the team's work, and we managed to address the needs of 50 women in the Cochrane area and surroundings. These are people who live in rural settings, and they were transported via bus to the hospital of Chile Chico, where the exams were carried out. We're going to carry out a second team to be able to further extend coverage to more women. The photos you see, or you saw earlier, are the photos of the rural area of San Lorenzo, Chiavis, the Rio Vaque area. There you see them on the screen. The first photo where you see the snow-capped mountain and the fence is San Lorenzo. The second photo is Rio Vaque. And the third photo, that third picture, it's a distant picture of our village. Thank you so much for your attention.
Thank you very much, Ariana. I appreciate the presentation. And we're going to now move quickly to our last speaker, Dr. Luis Peachy. He is a Gid-Ime man from the Jidibag-Iggan language group with the rainforest people of North Queensland. He is a senior medical officer at the Atherton District Hospital. He is the founding president of the Australian Indigenous Doctors Association, and he has been an advocate for rural and Indigenous health for more than 3 decades. He will speak about how community control for Indigenous health policy in Australia has played a key role in setting health priorities and policies and as concern for Indigenous people. Dr. Peachy?
Thank you very much. I'd just like to acknowledge the elders and ancestors of all of the Indigenous peoples who are represented on this webinar. So look, I'll try and keep my presentation fairly brief. There has only been one successful strategy for the engagement of Indigenous health in this country, and that has been community control. It's essential to have Aboriginal people in charge of their own healthcare and in charge of their own health priorities. Ours is an interesting country. Australia has about 26 million people, and there's about approximately 800,000 who identify as Indigenous. There are the two substantive cultures within our Indigenous people, mainland Aboriginal people and Torres Strait Island people. The Torres Strait is a archipelago of islands that exists between the Cape York Peninsula and neighbouring Papua New Guinea. For the first, Australia was federated into a federation of 6 colonies in 1901. Unfortunately, was at that project was the beginning of some terribly racist policies. One of the first pieces of legislation that was debated in our parliament was the Immigration Restriction Act, which basically excluded all black and brown people from emigrating to Australia. They wanted to have a white colony. One of the second substantive pieces of legislation to be debated now in Parliament in 1902 was the Franchise Act, or later called the Electoral Act. There was a quite significant debate in that, all about excluding black and brown people, but particularly some fairly vile conversation that was had to actively exclude Aboriginal people. Even in the making of our constitution, for the first 2/3 of a decade, the Australian Constitution actively excluded Aboriginal people. Although there was a census occurring, first Australian census happened in 1911, then about every 10 years until 1961, and every 5 years after that. The first time Aboriginal people were counted on a census was in 1971. So 70 years had passed of federation before Aboriginal people were actually allowed to be counted in numbers at all. Prior to that, the Constitution had actually forbidden it. So around about 1971 is also when we saw the first Aboriginal Medical Service come into being, and that was the Redfern Aboriginal Medical Service. Essentially, a core group of Aboriginal people had recognised that there was inappropriate care or absent care being given to Aboriginal people for their health care, and so they got together and they created their own health service. In the early days, a lot of these places had wonderful Australian doctors, many of whom, in fact, volunteered pro bono to staff, as well as nursing staff, often non-Indigenous and often pro bono, along with some Aboriginal health workers. The first significant Aboriginal health worker at Redfern was a lady called Mum Sherrill. In the meantime, in 1975, they developed the National Association of Community Controlled Health Organisations, which now represent a little over 140 Aboriginal medical services around the country. The whole point of a community controlled health service is that the priorities are that there was be a local board of Aboriginal people who actually determine what the health priorities are for that. The thing that okay, sorry, I've got some positive feedback in my speech now. The substantive difference sorry, there's positive feedback in the voice. I'm not sure how that's happening. the substantive difference that we saw that's come about from having the community controlled health organisations. Before those organisations were invented, the life expectancy gap between Indigenous and non-Indigenous Australians is about 25 years. Now, the better part of 50 years since the development of the Redfern AS, we've seen the life expectancy gap drop from 25 years down to only 9 years. 9 years is 9 years too much, but it's 16 years better than what it used to be. The most recent example of the effectiveness of the community-controlled health organisations has actually been with COVID in this country. So when the pandemic, and look, Australia has fared much better than most other countries. So this might sound like whinging about how tough things are here, because we've done extraordinarily well as a country. So Australia has only had about 36,500 cases all told. Of those total cases, there's only been about 150 are Indigenous Australian. None of those people were elders. None of them, no Indigenous Australians have passed away from COVID, and a lot of that was owed to the way that the community-controlled health sector moved in very, very quickly to make sure that there was proper quarantining and isolation, and to actually prevent the disease from getting into the communities. Since the vaccinations have become available, that in fact the community-controlled health sector has been integral to rolling that out in our Indigenous communities, and has actually had we've probably had less immunisation hesitancy in Indigenous communities than there are in the broader community. In Australia at the moment, the people who are most hesitant about getting the vaccine would appear to be old white people who've had an incredibly easy life, and they're waiting for a better vaccine. It's both sad and oddly comical at the same time, unfortunately. The other thing that's happened over the last 50 years is the number of Indigenous health practitioners have actually increased. So there's quite a few thousand Aboriginal people have graduated from nursing. There's about a little over 3,000 active Indigenous nurses still in the workforce these days. At the time that I graduated 30 years ago, there was one Indigenous doctor, that's Professor Helen Milroy. These days there's around about 500 Indigenous doctors in the country. The other thing that has been pivotal to the progress of Aboriginal people is actually the social determinants of health. Healthcare work has actually been a class escalator. So the numbers of Aboriginal people, Aboriginal and Torres Strait Islander people who are working as health workers and registered nurses and doctors and the allied health professions, that by itself has actually been a significant influence, allowing the next generation of children to come through to then start having dreams and aspirations, and the same sort of dreams and aspirations as other people. But it's the only intervention that works. And the biggest issue that we have ongoing is for Indigenous. We have no treaty with the Australian government or any Australian government. So we were excluded from the citizenry at the foundation of federation. When we were finally accepted in, we really don't have a particular voice. In 1967, we were allowed to be counted among the number of Australians. 50 years after that, there was a constitutional committee that were looking at what needs to happen, and a piece of poetry was put forward called the Uluru Statement, which ultimately asks for a three-part quest, is that Aboriginal people, Torres Strait Islander people should have a voice, and we should have a treaty, and we should have a truth commission. And we're still waiting for that voice to come about. Certainly our federal government is very concerned about sharing any sort of power or authority with Aboriginal people. So much so that when the statement was first published, both our Deputy Prime Minister and our Prime Minister told terrible untruths to the people, that Aboriginal people were actually trying to create a third chamber in our Parliament, which was just never true. It was known to be a myth, and unfortunately these two men lied to the Australian public, which terribly undermined our progress to getting these things. The thing that we found over and over again, the reason why we need to have an Indigenous voice, speaking for Indigenous Australians, is regardless of what we say, it doesn't matter how well educated we are, non-Indigenous Australians, largely Anglo-Australians, will interpret whatever we say through their own paradigm, and often come up with conclusions which bear no relationship to what it is that we've said to them in the first place. So that's where we are in our struggle today. We are very fortunate that we have a lot of incredibly good Australian people with big hearts and very generous hearts who are supporting us, and the current support for the Uluru Statement is about 2/3 of Australians who would like to see that resolution. Thank you, everybody.
Thank you very much, Dr. Peachy. I see a lot of parallels between there and here in the United States. Except, unfortunately, we've had a lot more death and COVID cases in our community. So, yes. Congratulations on that. I wanted to take a second and thank Dr. Wallet for giving us a blessing and prayer in her language. And I wanted to take a second and ask Francine Lasler to provide a closing prayer before I and Theodora provide brief closing remarks here today. So Francine, if you could give us a closing prayer.
Thank you. I know that Indigenous people, we all have our own spirituality. And so for, our community, we always start with the opening and closing prayer. And so, we'd like to thank the Creator for this day and all that it may bring. May the Creator continue to guide our work for our communities to improve health, equity, and well-being for our Indigenous people. May our work assist the world to see the importance and contributions of Indigenous communities, and may each of you be blessed and your hearts filled with compassion for our Indigenous people, and to continue the work that you do in each of your communities. We thank you for all your presentations and all that you do for your people, which will then impact other people throughout the world. We thank you and ask the Creator to bless each and every one of us as we continue our day, and those of you who will be ending your day, may you have a good night. And thank you so much. Amen.
Thank you. Thank you very much. I appreciate that, and I'm glad we were able to do that in the right way. I wanted to first of all thank the interpreters for sticking with us. I appreciate it. And I also want to thank all of you for a rich discussion today and for presenting these relevant interventions in which leadership, social participation, real engagement, and inclusion of Indigenous peoples were key in reducing inequities, responding to health emergencies, and ensuring a progressive universalism to health. As we have heard from our panelists, it is critical to ensure Indigenous leadership, participation, and representation in the planning and delivery of health services, because there is a strong correlation between the health of individuals and communities, the exercise or denial of their individuals and collective rights. In particular, leadership and participation of Indigenous peoples is needed in the design and implementation of culturally sensitive programs and interventions, and to overcome barriers to health services that they may experience. In ensuring real participation for Indigenous people, I'd like to emphasize the need that Indigenous peoples' representatives be determined through a process of Indigenous peoples themselves. Consideration should be given as well to the appropriate time to allow Indigenous peoples to engage their own decision-making process and participate effectively in decisions taken in a manner consistent with their cultural and social traditions. Thus, leadership, inclusion, and participation often mean establishing an intercultural dialogue from the standpoint of equality and mutual respect, thereby contributing to better health outcomes and progress towards universal health. Likewise, I'd like to stress the importance of ensuring women's participation and leadership in this process. As we have heard today, Indigenous women play a central role as community organizers and as the first responders to questions that affect them and their communities. In the context of rural and remote areas, some considerations to reduce inequities in access to health and ensuring progressive universalism include training health workers from Indigenous communities, improving education, and affirmative action for Indigenous students to undertake learning experiences. We also require cross-sectoral action to address social determinants of health, including structural racism, and due attention to the intersections between racial discrimination and discrimination on different grounds, such as gender, income, occupation, education, migrant status, sexual orientation, and others. Finally, we need to overcome barriers to participation, which can be experienced by Indigenous people living in rural and remote areas, such as distance, language, and information and computer technology barriers, some of which we saw today. Time and opportunity cost barriers, lack of culturally appropriate participatory platforms, and limited training of health sector professionals and community in participatory approaches and practices. I'd like to make a call to strengthen the strategic partnerships and inclusion of Indigenous peoples in all decisions affecting their lives, ensuring their leadership and representation in the development of initiatives and activities within the UN system, health authorities, other state institutions, local organizations, and the general population to foster action to increase inclusion, equity, and equality. I want to also make a call for the funding of these efforts globally from member states, partnerships through the World Bank, NGOs, private industry, and the philanthropic community, and to ensure that these efforts remain Indigenous-led. Colleagues, I look forward to our continued engagement for the health of Indigenous peoples, including in the context of the new social contract. Thank you so much to the speakers and all the participants who joined this event. I'd like to now turn it over to Theodora. Theodora?
Thank you. And thank you, speakers, for your very insightful and important interventions. And Jeffrey, you've done an excellent job in sharing, so thank you very much. I'd also like to thank all the participants for their attendance. And we look forward to working with all of you to support the right of Indigenous peoples, including in the context of the right to health and also in the context of the new social contract. With regard to the wider webinar series, I'd like to thank the Wonka World Working Party, OECD, UNDESA, FAO, IFAD, and other agencies of the Inequalities Task Team for their partnership in organizing not only this event, but also the wider webinar series. A special gratitude goes out to Susana Gomez, who has really been tirelessly organizing the work for this webinar series and this event in particular, and also to Claudia Quiros for its promotion, and Nono Simile and Mingwei Kang for their support to work on ethnicity and health and also rural health equity. Finally, with just some closing words regarding our next event in the Rural Health Equity webinar series. It'll take place on the 15th of October. It's specifically dedicated to policies to develop, attract, recruit, and retrain health workers in rural and remote areas. and promote gender equality for rural women through health workforce policies. And we really hope to see all of you there. Again, it's been an honor to be here with you all. Thank you very much to the speakers and also the chair. And we do look forward to further collaboration with you on this essential topic. Thank you.